Welcome to Straight from the Source, a podcast from FMOL Health. Here, healthcare is a verb. It's how we show up every day, boldly, joyfully, and with great love. Heart disease is still the leading cause of death in the U.S., but most of us don't think about our heart until something goes wrong. Today, we're joined with someone who sees the consequences up close. We're joined by Dr. David Theodoro, cardiothoracic surgeon at FMOL Health, St. Dominic, here in Jackson, Mississippi. Welcome, Dr. Theodoro. We're so glad you're here.
It's my pleasure to be here.
Nearly 30 years of experience in the clinical arena, 25 years in St. Louis, nearly 25 years in St. Louis. You led a team that led the largest minimally invasive valve program in Missouri history.
That is absolutely true. I had the pleasure and the honor of doing that. We started off with a minimally invasive platform primarily directed towards problems with the mitral valve and the aortic valve as well, but primarily the mitral valve. And that by and large was an approach to the mitral valve that avoided a sternotomy, the splitting or the breaking of the breastplate bone, and entered through a small incision on the right chest, and then evolved that to include the Da Vinci robot platform. And so we led the largest and quite frankly the only robotic cardiac platform in that time frame in the state of Missouri.
That Da Vinci robot platform is now used at FMOL Health. We just saw one with Dr. Marks in Our Lady of the Lake, Baton Rouge, where he's using the Da Vinci program as well.
The Da Vinci robot platform is now used across many, many different surgical disciplines and continues to grow.
You're chief of cardiac surgery here at St. Dominic's. Will you start by telling us about yourself and the path that led you here?
As a child, I had exposure through some medical issues to medical teams and surgeons in particular, orthopedic surgeons in specific, that gave me a little bit of a different and maybe early view. Not that I knew it or wanted it at that particular point in time, but nonetheless, it came. It was part of life, and that exposed me to that discipline, that field, and I guess in retrospect really did spark an interest that never left. I enjoyed the sciences and chose a undergraduate degree in chemical engineering, which checked a lot of boxes in regards to the requirements for medical school. And at the completion of chemical engineering undergraduate degree, I immediately began medical school and introduced to a lot of different disciplines, most of which I really liked, but cardiac surgery in particular was the one that caught my interest early on.
Operating in a room, probably something similar to this. Can you give us an idea or an explanation of a lab and what this is used for? Or can you describe other labs that are connected to cardiovascular or the cardiac team?
Yeah, sure. Most specifically, a cardiac surgery operating room is where I spend the vast majority of my time. Of course, we're in an EP lab here, which has some similarities to a cardiac surgery operating room. And in particular, just the level of sophistication that we can bring to bear to monitor a patient, be it in this EP lab or in our cardiac surgery lab or the hybrid lab, for instance, is really second to none. In cardiac surgery, there are, it really is the ultimate team sport. There's, of course, the cardiac surgeon and their immediate team, but there are vital, important, in fact, all of the positions in cardiac surgery, OR, are vital. There are people who, of course, manage the patient from an anesthesia standpoint who are highly trained specifically in matters of cardiac surgery. There are experts that set up and run and manage what we call the heart-lung machine, and a whole host of other folks that are actually at the table participating in, again, a very valuable and important and irreplaceable role to perform cardiac surgery.
Let's zoom out 10,000 feet and let's look right down at Mississippi in the South. And let's talk about some of the heart challenges or heart health challenges you see more often in the South.
Well, I'll tell you again, as you mentioned, somewhere between 23 and 24 years spent in St. Louis, which is not that far. It literally is 450 or so miles due north. But the distance is more than you would perhaps think that it would be when it comes to the pervasiveness of cardiac or heart problems here in what I guess we would all consider the deep, deep South. And there really are ramifications. There's ramifications from a demographic diversity. There's ramifications from healthcare disparities. Of course, that's a dynamic that is prevalent throughout the United States, but certainly here in the South and in Mississippi, in particular, having a chance to index what I see here over the past 5 years and compare that to the preceding 23 or 24 years, it's worse. There is no doubt the degree of healthcare literacy, the degree of disparities when you move out of major metropolitan areas such as Jackson and into, for instance, the Mississippi Delta, over towards the eastern part of the state down Interstate 20, western part of the state towards Vicksburg and in Natchez, we really do see tremendous variation in the natural history, the progression of cardiovascular type problems, heart disease, valve disease, congestive heart failure types of problems that certainly come home to roost in many ways that are not necessarily good ways at all at time of heart surgery. So healthcare disparity and variation in care alive and well in the South. Unfortunately.
Unfortunately,
Yeah.
but let's stay right there for a second. We talked about those demographics, right, and the disparity between those two. And it's Heart Month, also this Black History Month. Can you talk about the disparities of the challenges people face here in Jackson?
Yeah, absolutely. So in regards to the Mississippi Heart and Vascular Institute, MHVI, a storied history, a wonderful history, 52 years now. And what really what is embodied by the MHVI is just excellence over now decades. Excellence from a cardiovascular delivery platform, which includes our cardiology colleagues, our electrophysiologists, which is sort of a super specialty of our cardiologists, our interventional cardiologists, and of course, the cardiac surgery platform, and then all of the ancillary spheres of other expertise brought to bear for our patients. And so while, yes, there are disparities with regards to the timeliness of diagnoses and the degree of the natural progression of various heart problems, once they get into our arena, everyone is treated completely equally with I will tell you, I've seen bias before. I see no bias here. I see disparity when they get here. I see excellence at scale delivered towards these problems, however bad they may be and however much disparity they may represent.
Let's talk about a little bit about the operating room itself and what you see in that operating room or those operating rooms. What's something that most people wouldn't expect or not realize, when you're in an operating room, or what would they not see, from a regular person standpoint?
That's a really big question. So when we're talking with patients, we obviously have the opportunity, the privilege, the honor of seeing patients as they are going through sort of the diagnostic process, be that seeing them in our office or in the hospital. And the natural progression through the system would be primary care doctor making a referral generally to our cardiology colleagues at Jackson Heart Clinic, and then sophisticated levels of diagnostic technology brought to bear, and then those patients who can be benefited from cardiac surgery are then introduced to our team. And so when we're talking, to answer your question, when we're talking about coronary artery disease and calcium in the coronaries and blocked coronaries and valves that are either leaky and don't shut right, or they're stiff and tight and blocked and don't open right. We have fancy terms for that, but it's either they're leaky or they're too tight. Heart muscle that has changed its natural God-given shape. We can explain that to the greatest degree possible, but to see that disease manifested in the cardiac operating room. Very few people get to see that. So the heart surgeon and their team get to see it. The cardiologists see it when they are visiting our heart operating rooms. But that's really very difficult to convey adequately to patient and their family. So we have an unfair advantage because we see it a lot, unfortunately, and we see it up close and personal. So the degree of blockage, the calcium, and I always explain calcium as rock-like, if you will. So if something's calcified, it's hard like a rock. And if a valve is not moving, it's stiff like a piece of old boot leather with rocks implanted. So I try to use some visuals and some graphics to help folks understand what we're actually seeing in the cardiac operating room, to give them some basis on which to, understand what severe calcific aortic valve stenosis is. So what I just rattled off was, it doesn't really mean a whole lot to most people, but an aortic valve that used to have the consistency, the pliability of 1 or 2 layers of saran wrap, to then be able to be flexible enough to do what it's designed to do, but then evolves through a host of different processes in a number of years that literally turns into what I just mentioned, thick boot leather with rocks implanted in it, gives almost anybody now an idea. If it took saran wrap flexibility for the valve to work well, and now it's boot leather with rocks implanted, it doesn't work that good anymore. And everybody kind of understands that. And so, but we see it, to answer your question again, we see that up close and personal in the operating room.
We'll get back to your analogies, but
Yeah.
this question is more so like, are there times where you're in the operating room and you say, if this was 6 months ago or a year and we caught this could have turned out differently? Are there moments, or is there an example?
Yes, there are. And it really does. I'm gonna circle right back to what I was talking about, and that is, especially in the valvular heart surgery arena, when valves go bad, and really all a valve is meant to do is to allow the efficient and effective one-way transfer or transport of blood, and in doing so, a valve has to open freely and close tightly. And when either of those two functions go awry, go off course, if you will, and do so bad enough, it's really very important to get to that problem as early as possible. And so what we see in the operating room in many cases is, for a host of reasons, a delay in that process, and sort of the downstream effect of that delay can change the shape and the size of the heart, certainly affect negatively the overall pump function of the heart. And those are the times when, either out loud or certainly to ourselves, we would suggest that, boy, if we got this earlier, had an opportunity to intervene earlier, we wouldn't be seeing some of the bad things that come along with that problem.
Now as to the analogies that you like to bring up. I don't know if you are a big sports fan, but I like to compare, in my research, right? I like to compare you surgeons as like a safety in football or a goalie in soccer.
Interesting.
You're the last line of defense.
Yeah.
In a sense. So what's something you wish people knew or understood before they have to see a surgeon like yourself? What's something that, they could easily change that before they have to see you?
I'd have to start with just the heightened level of awareness, and I can't place that on the patient. I really have to place that on the healthcare team, whatever that may be, who sees these patients well before they, get to the cardiologist or get to the cardiac surgeon in particular. And so it's certainly a level of awareness. It's a degree of vigilance on not only the patient, but the healthcare provider, because this is a disease process that both the cardiologists and the heart surgeons deal with that has a very significant time component to it. So when I say awareness and early detection and vigilance and lack of complacency, it really is all tied into the early detection and treatment of these problems. Otherwise, just like I said, saran wrap flexibility turns into boot leather with rocks in it. The heart that should have, to use your sports analogy a little further, that should have the shape, a conical shape that I describe as half of a football, the larger piece, and of course the nose cone. And when certain valve problems are allowed to go too long, that football turns into a sphere or a soccer ball. So we have the transformation of a football geometry or shape to a soccer ball. And every single heart that goes through that transformation weakens anywhere from moderately to severely from an overall ability to pump blood. And so timeliness is going to be my final word.
Got it. You also compare, I think, a bypass to fancy plumbing.
It is.
Can you elaborate a little bit?
Absolutely.
Yes.
So when a patient has blocked coronary arteries, and God has given us all three major coronary arteries, one on the right side and two on the left front and left back. So we have three major distributions. And just like branches on a tree, the further you go downstream, the more branches in each of those major three arteries there are. And when blockages occur that interfere with blood supply, and those blockages, for instance, and for sake of this conversation, can't be treated with either medicines or angioplasty and stenting, which is what our cardiology colleagues do as their treatment of choice for blockage. Then they come to the heart surgeon. Then the fancy plumbing begins, because we acknowledge where the blocks are, but our job is to basically build a brand new coronary artery and splice in above the block and splice in below the block and create a brand new pathway for blood to then flow around the blockage. So in essence, we reduce ourselves to fancy plumbers. And that's where that analogy has come from, which is exactly what we do.
At least you're not showing up at someone's house to do it.
That is true. They're showing up at ours.
Let's talk about symptoms, right? Chest pain and left arm pain are usually the two things that most people will bring up when they're referencing their heart. Are there any other symptoms that people should be aware of?
Yeah, when you talk about chest pain, and I'll oftentimes ask a patient that I know has had coronary disease, or they really wouldn't be in my office, or I wouldn't be seeing them in their room after a diagnosis has been made. And a lot of patients distinguish between what ordinarily would be considered pain and pressure. So a sort of a tightness, a squeezing, a heaviness, a pressure would be much more common for coronary artery blockage disease or problems than what you and I might think of as sharp pain, stabbing pain, if you will. That's almost never the case. It's almost always the case that it's a heaviness, it's a pressure, it's dull, it's achy, it's naggy, and there certainly can be left arm pain, there can be left neck pain, there can be both side arm and pain. And interestingly, between a male, and their classic presentation with regards to symptoms, we've just discussed them. They can be for likely unknown reasons, significantly different, more subtle, more nuanced in our female patients. Not uncommon at all that fatigue, shortness of breath, non-specific muscle aches and pains, some arm pain, some neck pain, enough that unless the treatment team, whoever that may be, the primary care physicians, the nurse practitioner in the community, the emergency department, unless there's an elevated sense of awareness and worry, oftentimes, and indigestion, by the way, is not uncommon, especially in our women. Patient can happen in both men and women. Those subtle kind of one-off symptoms can sometimes be missed, and they're more likely to be missed, unfortunately, and at scale in our female patients.
Wow. To that effect, what are some of the simplest things people can do now to protect their heart health? Also, when should someone go and get checked about the heart?
Those are great questions. They're big questions. They're open-ended questions, and really good questions. Education, literacy in regards to your family history, your social circles, and an awareness of the typical symptoms that may relate to heart problems. Certainly shortness of breath, you've mentioned that, dullness, achy, chest discomfort, especially after either a big meal or in particular with some degree of exertion, can be bringing the groceries in from the supermarket to the house, can be running up to the upstairs floor of the house, or it can be during exercise, and new or odd or unexplained easy fatigability. In other words, you get tired, can't quite exercise like you used to, got short of breath when you're doing things that used to not cause shortness of breath. And then certainly the obvious ones of neck, arm, or in particular chest pain, those just cannot be ignored. We have any number of non-invasive diagnostic studies and modalities that are really designed to be sort of have mass appeal, so to speak, in terms of trying to uncover some of these problems. So it's really pay attention to your body. Don't ignore shortness of breath and certainly chest discomfort. And even something as subtle as indigestion and fatigability should be taken seriously. This is a process, or a disease sort of situation that if any of those things are there, and certainly there over a period of time, and they're abnormal, the mindset is there's a problem until proven otherwise. It's just the right vigilant mindset. Otherwise, it's complacency.
Through your illustrious career, you've probably seen tons, hundreds, say surgeries. Has there been
like thousands and 10,000?
I didn't want to, underdo it or over.
It's a lot.
Is there something like you've learned about your heart, your own health, that has made you, okay, I should change based on what I've seen throughout my career?
Yeah, you mentioned when we were off camera the disdain for fast foods. I would say that's probably not always been the case, and to understand that even at a relatively young age, sometimes shockingly young, plaque can begin to build in coronary arteries. I mean, in the 20s, certainly in the 30s, by all means, and so. It isn't a free lunch to do the fast food thing all through childhood, through teenage years, and through college years, and think that by the time you get to 30 that there's no ramification for that. So I think that's been important. Would I say that I've learned that at the right age, or the ripe age of 25? No, but now that we see a wider and wider age range of really significant coronary artery, in particular coronary artery blockage problems, it has made all of us, and certainly me included, more aware of the seriousness of this widespread problem.
All right. Off that subject, we're going to transition a little bit. We want to talk about you for a second. Joyfulness of spirit is one of our pillars here. What's something that's bringing you joy?
Certainly from a selfish standpoint, I don't want to juxtapose selfish next to joy, but from a cardiac surgery standpoint, that sounds better. The immediacy of an intervention and its result in a patient's life, their health life, and in particular their total life, because this disease process that you and I are talking about really is a life shortener, a life ender, and just really a ubiquitous, disastrous problem at scale. And to be able to, as our cardiology colleagues, they say the same thing with regards to the immediacy and the effectiveness of angioplasty and stenting and the valve implantations that they do. But in regards to cardiac surgery, I would say that is super joyful. Also very joyful to watch in my time of doing this some very significant technological advancements. We talked a little bit about minimally invasive surgery, et cetera. The manner in which we can now support really, really weak hearts has advanced significantly, even in the last, I'd say 5 or so years. That's joyful. I would say that the team spirit, sort of the heart team dynamic, which is really ushered in again at scale with the advent of technology that allows our cardiologists, and in conjunction with cardiac surgery, to deliver brand new heart aortic valves without standard surgery, without conventional surgery, I should say, and that has pushed both of those specialties together in a really, really good way. And I would say that, does that elevate to joy? Probably, yeah. I'll ask my cardiology colleagues that, and hopefully they would say the same. But the team spirit really like to come together around these super sick patients and watch the great work that our teams in the operating room do. Kind of mention them. I'd be remiss if I didn't talk about the absolutely vital importance of our nursing staff in a cardiac ICU. It is really. It's remarkably important, absolutely adjacent in its importance to we coming together as a team in the operating room. We come together as a team in the ICU. It is really very special to watch that. That's joyful.
It seems like you love what you do.
I do.
And here at FMOL Health, we do things with great love. What's something you've seen recently that made you feel the heart of this health system?
The sisters on, pre-FMOL Health and now post-FMOL Health have really set the fundamental core mission right in the center. And the system that I came from in St. Louis was similarly a large Catholic institution and founded by the sisters, no different than we here. And that mission is the center and the North Star of everything we do. And I see and feel that here, palpable. It is really palpable. And I think that, it reminds us every day of our purpose and our mission and the vision that we have for growth. And, growth, of course, is stemmed by taking this team that we've developed in particular in MHVI and scaling it to the greatest degree that we can, because we think we do it really good, and we do it really good. And the need is really high, and we want to marry what we do good, excellent, to the need. And center that on the mission that was established here, almost ages ago.
That's a great segue to my final question. What's one thing you hoped people, if they watch this, that they learn about yourself and what you do here?
Yeah, well, certainly it's not about me, but it clearly is an awareness of this problem, an awareness of what we're trying to do here, and that is educate and make timely diagnoses and thorough and excellent diagnoses so we can plan and deliver the skill sets and the technologies that we have at our disposal, and help as many people as we possibly can. But it really starts in the community. In the communities, the despair, some of the communities that are on the fringe, if you will, the Mississippi Delta, Meridian, down south. And I will really tell you, this is an interesting state in that if you are fortunate enough to be within the catchment area of the bubble of Jackson, Mississippi, it's phenomenal care. And I'm sure there are other bubbles. I'm sure Hattiesburg got a bubble, and Tupelo's got a bubble, and a couple other people. But I'm here to talk about what happens in Jackson. And the care is excellent, really across the board. But what is very unique, and again, I don't have firsthand experience of other southern states, but I'll make the comparison between Mississippi and St. Louis. The degree of fall off, if you will, when you are outside, and I'm sure there's other better terms than the Jackson bubble, which I'm presenting as good from a healthcare perspective and other perspectives, the fall off is very significant. So but again, multifactorial. There is no human to point a finger at. It's culture, it's literacy, it's access. We didn't really talk too much about access, but in rural healthcare, that there's a push across the nation to put special focus on rural healthcare. I think that Mississippi stands as a flag bearer to some degree on opportunity to improve rural healthcare. I think it's probably the best way to state that. And in that regard, lots of joy comes from seeing efforts to penetrate these communities that have heretofore been on the fringe, and help as many people in those communities as we possibly can. without question.
Beautifully said. Thank you, Dr. Theodoro. We appreciate your time. We appreciate your efforts.
It is my distinct pleasure and honor. We're blessed to be here.
To our audience, thanks for tuning in. We'll have helpful resources linked in the show notes. We'll be back soon with more episodes of Straight from the Source, a podcast from FMOL Health. If you have ideas of topics you'd like to hear on the show, email us at podcast@fmolhs.org.